Okay, let's get everyone on. Evening, everyone. Kish, can we see everyone cool?
All good, all good.
Okay, so evening to each and every one of you. Thank you for joining us on another big Monday Night Live. It's Monday the 8th of June, and it's been the first day back for many of us into the new normality of dentistry. So I definitely wish all of your days were okay, everything was safe. And again, this process will take a bit of time for us to learn and adapt, but it's good to see everyone joining on today as well. Today, we're going to have a really special day. We've got one of our good friends and the king of rubber dam. A lot of guys, you would have heard him around the country in the UK. Harmeet Grewal will be talking about rubber dam and isolation. And today joining us, we are also got John Nicholas, one of our mentors, one of our dentists with the Smile Dental Academy, and with Kish as well. Now, last week we had dental training consultants doing a DFT day. I know a lot of you guys enjoyed it. Sorry I could not be with you guys. Congratulations to all the winners. So we actually, Shivana and Zahid were actually going to give out one prize. In the end, they ended up giving out 16 different prizes to all the universities. So congratulations to you. Those of you guys who did win, do contact Shivana and Zahid, and they will secure your places on the course as well. A lot of you guys have been asking about Janos Mako's prize. Now, Janos was meant to join us in July. We're all aware of the restrictions in the UK here with quarantine and 14-day quarantine. Because we haven't finalized his booking in the UK here, because of the UK regulations, we're not going to release the details of the winner until later this week, once I've got that date sorted. So do keep watching us on Instagram, keep a tab on it, and we'll release the details soon. So Kish, how was your week been, past week?
It's been an interesting week, to say the least. I know it's been a lot of chaos with the media kind of saying that we can reopen, and I think we had, 6 SOPs come out in 7 days. So there's been a lot of chaos and not a lot of time for a lot of the practices to prepare. So it's been an interesting week. It's been very, very busy. But as I said, for us, for myself and Jin, for all of our practices, the number one priority has been the safety of our staff and our patients. And that is exactly what we've been working towards for today's reopening. So it's been an interesting week, to say the least.
Now, some of you guys may have seen we've created specific SOPs, staff flow charts, and patient flow charts. If anyone does want hold of these and wants to edit them, or if you need any help at all, do reach out to myself, Kish, or Jin to help you guys out. The whole reason we set these webinars up right at the beginning is to help the community, the dental community out, and bringing everyone together. As we're reopening, we will need everyone's support, from the reception team to the nurses, admin team, dentists, therapists. We all need to work together in this new uncharted territory we're entering. So if anyone needs any help or needs any flow charts, do reach out to us and we will help you out. As I said to you, we're honored to have John with us today. So John is one of our dentists who heads up our diploma for therapists as well. And I thought this is a big topic, and I thought it'd be good to introduce John today and see what he's been up to and how everything's getting along. So John, how you been keeping, buddy?
Been very well, thank you. Been enjoying my time off, but I think it's come to a point where I've got to get back now because I'm turning a bit too lazy. I've run out of things to do, so it's going a bit downhill now, so I'm ready. But yeah, as you mentioned, therapist course we are launching this year. We're supposed to launch in March, but obviously due to obvious reasons, we've had to put it off. But I mean, we sat down, didn't we? And we spoke about therapists and how they're not being utilized enough. I mean, their scope of practice is huge. And a lot of dentists aren't even aware of how huge their scope of practice is. So we've given them a platform now really to push on, really kind of thrive. We give them a 12-day course. It's not kind of a 1 or a 2-day thing. This is the real deal. We're talking things like occlusion, smile design. We've got a day with Harmeet as well doing rubber dam. And it's just a really good opportunity for these guys. We're expecting them to come out the other end with a wealth of knowledge, enhanced skill set, and really we want them to be able to turn heads and become more employable, but also be utilised more within the dental team, more so than ever.
Fantastic.
And I think one, just to add to what you're saying, and I think you'll agree, is that what we've seen with the therapists that have joined on, the passion that they have for dentistry is amazing.
Definitely.
And they're so interested in trying to do more in practice, and we just want to be able to help them build on that platform that they've already got to be able to do more in clinical practice, right?
Brilliant. So a lot of you guys are messaging, asking more about this stuff. The best way is if you follow us on social media, on Instagram, Smile Dental Academy UK, follow Dr. Jin, Dr. Kish. We're out there, and any questions, drop us a message. We will help you out. But the reason we're all here tonight, and again, this was sort of planned in accordance to all the new regulations. We know that AGPs, aerosol generating procedures, are a big issue. And every faculty, whether it's UK or international, has recommended the use of rubber dam. Now, this is something a lot of clinicians, if you shied away from it, you've forgotten the skill, but this is now a safety thing. And we have got today, it was meant to be Harmeet, but it looks like Harmeet's come out of looking at new look today. Harmeet, how you doing? Looking good.
My head feels cold.
Good.
I feel lighter.
I'm just looking at you guys thinking, how have you maintained such immaculate hairdos?
I think it's been 12 weeks. I still haven't grown my hair as tall as Jin's. I don't know how long it's going to take.
You know, I was thinking today, I don't know what's going to scare my patients more, the new PPE or my hair. So, but Harmeet, how you been keeping, buddy?
I've been keeping well, you know. I've just been, you know how it is with kids. If anyone's on here who's got kids, you know how it is. But just been trying to keep them entertained, really. So I think it's probably a good thing because dentistry got kind of pushed to the back of my mind a little bit because you're just focusing on them. And it was good. Got a chance to just do things that you never get to do. So like John, got on the piano, learned a bit of that. And then, yeah, just getting out and about, really, on the bike, just trying to keep fit and just trying to entertain the kids. But yeah, it was good. It was good. But I think, yeah, I haven't started just yet. I mean, we're just in the process of getting PP. But yeah, I'm itching to get back now. So yeah, it'll be good just to get back to the swing of things.
Fantastic. I never gave you a full introduction, but Harmeet, not just Robert Dam King, he actually teaches the posterior composites on our courses. A very skilled clinician. So those of you guys who follow him, his work, and he might show some of it tonight. Very skilled clinician, works in fully private practice in the Royal Leamington Spa. Is that right?
Oh yes, it's royal indeed.
Royal. So, Kish, anything you want to add, buddy?
No, I was just going to say, I'm really looking forward to tonight. I've heard Harmeet speak quite a few times, and he's an excellent dentist, clinician. He's also a key opinion leader for GC as well. So he knows his stuff, and he is the master of isolation. So I'm really looking forward to tonight.
So we're not going to take too much of time. We're going to pass you over to the man of tonight, Harmeet Grewal, to take it away on rubber dam and isolation. And the reason I like his lectures, he keeps it very practical for us general practitioners and how we can apply it and use it in practice. So Harmeet, over to you, buddy.
Brilliant. Cheers, guys. That was a hell of an intro. All right, so what I'm going to do is I'm just going to share my screen. There we go. And guys, just let me know. Is that clear to you?
Press the play.
Press
ready? That's okay.
Yep.
That's cool.
You got it?
Yep.
All right, brilliant. Good. So yeah, I just want to thank the boys for having me, really. I mean, I always love working with them because, as you can tell, their energy is just great. Always positive. You know, always looking to do something new, and it's always just good fun working with them. But today I'm going to talk about rubber dam, and it's, I mean, obviously something now that's become, I guess, even more important with COVID. And hopefully today I can kind of share with you a few strategies that you can use, I guess, just to really aid you when it comes to your rubber dam placement in practice. But a little bit about myself. I mean, like the guys have said, I work in a private practice where I live in Leamington Spa, and it hasn't always been that way. So I do understand what it's like to work in a busy NHS practice, because that's what I did for the first 4 years of practicing. So I know what it's like to have time constraints and all these other things that can sometimes just kind of weigh on the back of your mind and sometimes affect the quality of the care that you might be providing, or sometimes just make you feel a little bit rushed and maybe prevent you from doing things like using rubber dam. But like I said, yeah, now in private practice, I get a bit more time on my hands. I do a bit of work for GC, so I lecture teaching kind of posterior and anterior composites using their Essentia system, and also soon to be doing some stuff on injection molding. But the main thing I do is obviously these rubber dam courses, and I guess it came about as a bit of a happy accident. I've used rubber dam for a long time, but it was something that there were no courses for. I had to learn it myself, and that was just trial and error. And inevitably, you do something enough, you get good at it. And my therapist came to me one day and she said, Harmeet, can you teach a group of us just a little bit about composite, a little bit about rubber dam? I said, all right, sure. Let me put something together. So I put together a bit of a course and I said, okay, it's going to be a bit too much squeezing rubber dam and composite into one day. So let's just do rubber dam first and try it out. And that's where it stemmed from. But I thought the only way to make this useful is rubber dam's a practical thing. Now, doing something on a typodont is of no use to anybody because you can learn the basic principle, but until you're actually doing it on a patient, you don't know. And that's where the kind of hands-on courses came about, where the delegates come and they actually do it on one another. And obviously you can imagine they get to experience what rubber dam's like. Okay, they get to do in real world environment, and every case is different. So it's really good learning opportunity because it means that you can really just implement everything you learn with confidence. And lastly, you know, I'm a dental tubular study club director, really proud to be involved in that from the beginning, and just think, for those of you who don't know, it is such a fantastic resource from CPD, PDPs, and just general, you know, just a general community from who you can get guidance and support. So definitely something worth checking out. But let's crack on, okay? Now, the guys mentioned Instagram. Had a bit of social media break during this whole kind of COVID situation, but I'm back on it. And if you want to know about courses and, you know, even just keep an eye on the work that I'm doing, I sometimes post things on there and you can get a few tips and whatnot from that. But first thing I'm going to talk about is mindset. And, you know, during this whole break, it's, you know, our mindsets have probably been affected a little bit. Some people in a good way, some people in a bad way, but mindset and strengthening your mindset, and especially having a growth mindset, is going to be really important, not just when implementing a new skill like rubber dam, any skill you come to learn in dentistry, because it's easy for me to teach you something, but then what you then go and do with it, and whether you actually put that into practice, some people do, some people don't, because some people see obstacles come in their way and it causes them to abandon their endeavors and give up on something, whereas other people, these obstacles will still come in their way, but they just keep trying to overcome them. And if you have that kind of mentality, you can put anything into practice and become successful, okay? Any aspect of dentistry. So just try and develop a bit of a growth mindset and think, you know what, I'm going to embrace failure and everything's a learning opportunity. And with that in mind, another thing to think about is we always want to be perfect as dentists. We want to do everything that we do in life perfectly the first time round, but that's just not possible. You've got to start somewhere. What I always think is start now, get perfect later. And was one of my, I think, very first few isolations. I was doing some composite work. Is it great isolation? No, probably not the best clamp I used. You can see gaps in the rubber dam where it's a little bit thin and stretched out. You got saliva and blood leaking, and in some areas it's not down through the contacts. It's not what I'd say is an Instagram perfect picture. However, that doesn't matter, okay, because our patients come first, but it does the job and it's a start. I can use that picture now, analyze that and think, where could I do better in the future? And photography is really helpful for those types of things. But rubber dam has been around for ages, 1864. So that's a long, long time. But even now, here in 2020, we're still slow on the uptake. And I think that comes down to, it's a topic that's often skimmed over. It's not given a lot of attention. It might be something that you learn on a composite course, but it's very brief, or you've learnt it at dental school, but again, very briefly, or you might have just been taught it, or for endodontic procedures where you're just using it for a single tooth. And inherently, other people's biases can sometimes come into play, and people telling you that you don't need to use it. But now you're going to see more than ever that you really do need to use it. And it's one of these things that you overlook, but actually is really going to help your dentistry massively. So why should you use it? So for adhesive dentistry, I say it's a must. And I say it's a must because I always use this logic with patients. I always use the logic of adhesive dentistry being you're just gluing two things together. And much like if you were at home doing some DIY, fixing something, and you were gluing two things together, you'd want things to be clean and dry for the glue to really hold and work. And that's all I think of when I think about adhesive dentistry. But then another reason is all the people that we are taught by, all the people who publish papers on adhesive dentistry, all the gurus. So we could talk about Pascal Magnier, we can talk about Didier Dici, just to name two. These guys are really top of their game. What's a common theme when we look at their work? They're using rubber dam. And there's obviously a reason for that. But there's bigger reasons than just adhesive dentistry. Stress-free practice. What we do is so stressful. We're working in such a small space, trying to do such fiddly work. And I think we forget that sometimes as well. And it can become very difficult then when, we've all had those patients, and they don't necessarily mean it, but they're anxious, they may have very large tongues, things become a real struggle. And I can remember the days of not having rubber dam, when you're there with like a matrix band around a tooth, about 1,000 cotton rolls, and saliva is like leaking in from everywhere. You're trying to pack in this composite and you cannot see a thing. And all the meanwhile, your hand's cramping up and you're just giving your nurse evils when it's not even her fault. When you put rubber dam on, suddenly it's just you and those teeth. Have to check in on the patient from time to time, okay? But it's just you and those teeth. And when it's just you and those teeth, that's when you can improve your clinical work, because you can suddenly concentrate on how you're layering that composite. You can concentrate on your bonding protocols. You can concentrate on, how your prep looks, smoothing those margins, all these things. And that combined with photography really takes your level of, clinical work to another level. And that's what I found. There was such a big jump once I started using rubber dam. So for me, just for these three reasons alone, it's just a no-brainer. But obviously, COVID's come along as well now. I want to talk more about that shortly. But as dentists, we always want some kind of evidence. And to be honest, there's no evidence out there. There's lots of papers that talk about the merits of rubber dam, but there's no go-to paper that would say for your composite restorations to be successful, you need to use rubber dam. Because to be honest, it's too hard to prove because there are too many variables. Because it doesn't just come down to rubber dam. It comes down to what's your bonding protocol, how you like curing, how are you placing those composite increments, what type of composite, all these sorts of things. And that's why you can never prove it. But I purely use those three reasons as my kind of basis and logic to use rubber dam. There's a Cochrane review on rubber dam, but at the end of it, it says there could be a lower failure rate of restorations, compared to using cotton rolls. But again, like any Cochrane review, what do they always say? Further research is needed. So it's not really conclusive. But for those of us doing endo, there's these guidelines that talk about deep caries and the exposed pulp. And what's their recommendation? Aseptic management. So trying to use rubber dam at all times to keep everything sterile. And it just makes sense. And these are all things that I was seeing, and I was thinking, gradually more and more things are going to start to point to rubber dam use. But then COVID came along, didn't it? And these are the kind of the latest guidelines. I know they're kind of always changing, but what does it say? Risk reduction of aerosol contamination can be achieved by using high-speed suction and use of a rubber dam. So it's become even more important than ever to use rubber dam as much as possible to protect yourself and your patients. And even Australia, I mean, they've taken it one step further. I think Jin sent me this and he said, have a look at this. And, you know, they're kind of making it almost mandatory that if you want to do any kind of AGP procedure, you have to use rubber dam. And then you have other guidelines. I mean, this is a bit suspect. Use dental dams to reduce contact with saliva or poo. I mean, interesting. The thing I like about this is the arousal techniques. Talking. If so, only someone had told me that at 16, that would have saved me a lot of aggro. But next thing I'm going to talk about, and this is really, really important, it's checklists. So I always talk about the aviation industry. Why is it, I mean, currently, obviously it's not great for them, but why have they been so successful as an industry? It's because they really do use checklists and really do embrace kind of this black box thinking mentality. So obviously if a plane crashes, they're hunting for the black box. Why? They want to know what went wrong. When they know what's gone wrong, they identify what they can do and implement in forms of a checklist to stop that from happening in the future again. So it ensures success. And also, it just makes sure that you're doing your job correctly. Because after a while, especially if you've been doing dentistry for long enough, you get on autopilot. You start doing things without even realizing. But the problem with that is sometimes if you're not having a good day, you can miss steps and forget things. But just by having a simple checklist, doesn't have to be pages and pages. Best kind of checklist is just kept to kind of 7 to 8 points. It just keeps you on track. It's good for your nurse as well. She knows what's coming. She knows what you're doing. And it means you're efficient. You're not just kind of chopping and changing what you're doing. And patients pick up on that. They know, you know, when you're working efficiently and everything's running smoothly. And they appreciate that. But I break down my rubber dam placement into these kind of 8 steps. And feel free to take a picture of this screen. But I'm going to briefly run through these. But essentially what I'm going to do today, because it's such a vast topic, the thing that I'm going to focus most on is choosing a clamp. And the reason I'm focusing on that more than anything, because that's where people come undone when I'm teaching courses and when I'm speaking to people. They haven't got the right clamps and they're not using them in the right way. And if you haven't got a clamp correctly on a tooth and you're not using the right clamps, you're already doomed for failure from the start. So if you can get that bit right, then the rest is going to come a lot easier. But if we talk about communication, okay, a lot of patients won't be used to rubber dam. So you need to explain what you're doing. You need to kind of tell them in a nice way. So I often say we're using this soft blue sheet that we gently place over your teeth, which is held in place with a little grip. And what that allows me to do is work kind of safely and concentrate on the work I'm doing, ensuring a really nice result. And it's really quite comfortable. A lot of my patients fall asleep with it on. It just sounds a lot nicer than I'm going to stick a clamp on your teeth and I'm going to put this rubber dam sheet over it. Just try and put it in patient-friendly language. And then things like anesthesia, again, sounds obvious. Just make sure they're numb. Certain clamps, especially metal clamps, they're going to hurt. So make sure you give them the appropriate anesthesia. It's better to have more than less because nothing's worse, than, as we know, than a patient who's feeling pain and uncomfortable. And last thing you want is you put that rubber dam on and you need to take it off to give a patient more anesthesia. And then we talk about flossing contacts, and that's more just to identify where the rubber dam is going to pass through or not. Choosing our clamp, which we'll talk about today, and then just putting your dam to your frame, and then marking your holes, punching your holes, and placing your dams. Okay, but there is a lot, and I'd love to teach everyone everything, but with the time I've got, I can't today. So like I said, I'm going to concentrate on the bit that I guess confuses people the most. So when we talk about clamps, we've got to know why are we using the clamp, first of all. And essentially, if you categorize clamps, you've got to put them into 2 categories. You have an anchor clamp. So an anchor clamp is essentially the clamp that goes on the most distal tooth. So it's what's keeping everything in place. and keeping everything secure. Okay. And then you'll always have that anchor clamp. Then you'll have accessory clamps. So accessory clamps are not an anchor clamp, but they're an additional clamp that you use. And you use them in cases where you want to maybe hold the dam past, deep cavity margins, or maybe past your preparation margins when you're cementing, onlays, veneer lays, or, veneers anteriorly. So it really does help for those types of things. Next bit is talking about the clamp anatomy. So the main thing with clamp anatomy is that we've got your bow, okay? And then you've got the beaks, okay? So you've got these 4 little beaks, and they're the most important part. But then you also have the main central wing, and then you have an anterior wing as well. So this is what you'd call, obviously, your wing clamp. And again, depends on your preference, really. It doesn't matter. I like to have wingless clamps. So imagine a wingless clamp is just that clamp without the anterior wings. The reason I like that is I sometimes find the anterior wings just get in the way, especially if you're working quite close to that clamp. And it can be quite, I guess, annoying if you're trying to use sectional matrix systems, because they actually prevent your sectional matrix systems from just engaging into the correct areas. So sometimes I like, all the time, I like to use wingless clamps. And if you haven't got any wingless clamps, you can turn that into a wingless clamp. Just take a high speed and just trim off those anterior wings. But the most important thing is those beaks. The other thing you want to look at is the angulation of those beaks, okay? Because some fairly flat, or some like this, you can see how they're angulated really quite apically. And that means you're going to get a bit more of an aggressive kind of grip onto the tooth. And you might need that in cases of broken down teeth, or you've got irregular shaped teeth, or partially erupted teeth. And again, you can customize your clamps to become like that just by using some pliers and just within limits, gently bending the clamps and customizing them to each tooth. But this is what I mean by about a 4-point contact. So this is a case where we've done some composite work. But what I want you to concentrate on is just the position of the clamp. We've got 4-point contact there, okay? And that's really important. But it's not just 4-point contact anywhere on the tooth. You've got to think about the shape of the tooth. So if we were to talk about the shape of a crown of the tooth, it essentially has, it's almost like a globe, isn't it? It kind of comes down, you have your maximum bulbosity of the tooth, and then it starts to kind of come in around the CEJ, okay? So you don't want the clamp, those beaks, to be engaging the tooth at the equator or above, because if, one, you might not get it on. If you are lucky enough for it to stay on, likelihood is when you come to put the rubber dam on over the clamp, it's going to come away. Or even worse, it might not, and then it just comes away mid-treatment, nothing worse. It needs to be engaged under that equator, okay? And that's the first thing I do. I often just try the clamp on the teeth just to see how it fits. And if it's, restorative case where you've got models, you can even do that in advance. Just take the patient's models out and, just try the clamp on the models and see how they fit. That's even better. So, when you start, you don't have to waste clamps. You just know what one's going to fit. But before you start, other things you have to think of, I guess, with the clamp selection is your plan of action. I always like this quote, you fail to plan, prepare to fail. And it's true. I mean, sometimes we plan our big cases, but we don't think about even just the small cases. Because actually, if you just spend just 5 minutes sometimes, end of your day or the day before that patient's due, just planning what you're going to do, think about, all right, how am I going to isolate this? Am I going to need to isolate 2 teeth, or should I isolate, a whole quadrant? You need to think, what surfaces am I going to need to access? Is it just going to be mesial distal, or is it going to be, I need to be accessing a lingual surface or a buccal surface? Is that going to be fairly superficial, or is that going to be deep? Okay, and then other things you have to look at is the contour of the tooth as well. All teeth aren't, contoured the same. And even cavities, they're not contoured the same. And the deeper the cavity becomes, the narrower the contour. So again, that's going to affect the type of clamp you choose. Because if you've got a real narrow contour, if you've got a clamp with beaks that are too far apart, they're going to start to kind of interfere with your working field. So you might need to choose a clamp that has beaks that are closer together. So maybe something like a premolar clamp. But we'll talk about the clamps I use. But here's a scenario, okay? We're doing some indirect restorations, but as you can see on the right-hand side, we've got anchor clamp, 4-point contact, but we need accessory clamps. The reason we need accessory clamps is because of the buckle margin being a little bit deeper. If I didn't have that clamp, I'd probably find that the dam rides up over the margins. And sometimes you still need additional things. And for me, PTFE is the absolute best tool that you can use because it's so useful. You can just roll it up into a certain thickness and just pack that down. It helps to just push the dam down a little bit further. And it also is really good at keeping everything watertight. So PTFE is really, really useful. Another great thing about that is as soon as I cement that indirect restoration, as I pull that PTFE out, it's going to take a lot of the flash away with it. So it's really quite useful. So let's go through the clamps that I use. So essentially, there's about 7 clamps that I use. I don't use any more than that. And that's what you want. You want to try and keep things simple. I'm going to show you the 7 clamps I use. By all means, you may have them, but go out and get them. And over time, find clamps that you like, okay? Because what I want you to take from this is the principles of using the clamps. You'll go into a catalogue and there'll be hundreds of clamps there saying that's for a lower premolar, that's for an upper molar. That doesn't really matter. The main thing is, have you got 4-point contact beneath the equator of the tooth and it's not interfering with your working field? That's all you need. And then it'll be stable. But the clamp I like to use is the Kerr soft clamp. Okay. And this is, I guess, the one I generally use for most molars, 80% of the time. It's useful on lower 7s and 6s and upper 6s. Really versatile, really nice clamp. And good thing with this is sometimes you can actually get away with this because it's a little bit more delicate. You don't always have to, in certain cases, it depends what you're doing. You don't have to always anaesthetize the patient for that. And then you have what we call the Brinker clamp, so the B1, B2, and B3. And now these are available from Goldstein, and they're technically known as gingival retractor clamps. And it just means that when they clamp the tooth, their beaks are angulated a little bit more apically, so they give you a bit more of aggressive grip onto the tooth. And it's really useful when you want, they're useful as accessory clamps. They're useful for difficult molars, and even when you've got broken down molars, or if you're doing indirect restoration, then you're cementing things. Generally, the B1 clamp at the top is for your lower molars. B2s are for upper left molars, and B3 upper right molars. Now, when you look at the B2 and B3, do you notice how on one side, how it's just kind of smaller than the other? The reason for that is that's best to be used on upper 7s, because upper 7s often have that triangular shape. And the beauty of having those beaks of those different sizes is meaning when you look at the buckle there, it's engaged nicely, but where it starts to become a bit more triangular towards a palatal, it can still grip. But the real beauty of this is that we were doing a MO restoration on that 7, but look how much space is clear there. If I'd used a winged clamp, I would have really struggled to then get my sectional matrices, wedge, and everything in place. So this just makes it a whole lot easier. And like I said, it's great for cementing onlays and things. Now, what I want you to know is this is a lower molar, but it's a B2 clamp, which I've said is an upper molar. Again, like I said, don't pay too much attention to that. The main thing is you've got 4-point contact on the tooth and it's stable. You can see how it's just taken the dam and holding it past my margins. And just looking at the picture, the only thing I'd probably do different today would be roll up a thick bit of PTFE and put it distal, so that when I kind of cement everything in place, I can just peel out the PTFE and it just takes the excess with it and just makes cleanup just a lot more easier. And then we come on to premolar clamps. So you got your 207s. They've got wings on them, and then the W2A. So these are the ones I prefer. But these are really useful when you're doing anterior work. Okay. And here's an example where we're doing anterior work. And generally, when you're doing anterior work, depending what you're doing, if it's 2 to 2, 3 to 3, I'll isolate probably 5 to 5 normally, or 4 to 4. And I always like to use clamps because clamps are the most secure thing you can have. I see people do it with kind of widget and, you know, floss, and by all means, you know, if that's all you've got at time, use that, because something's better than nothing. But often what you'll find is, especially on the lower arch, is patients are always pushing against it with their tongue. So if patients are pushing against it with their tongue and you've got something that's not held in firmly, it's going to come away. And there's nothing worse than being, you know, you've done all your bonding steps and you're starting to layer composite and your dam's starting to come away and leak. So by having the clamps in place, you just ensure that it just keeps everything where you need it to be, because you just don't need that stress of, you know, mid-treatment, everything starts to come away. And then we have the brink of the B4, so it's the kind of runt of the litter when it comes to those Coltine clamps. And it's quite a small little clamp, delicate little thing. So it requires a little bit of, you know, finesse and destabilizing it onto the teeth. But it's really useful when you're doing class 5 restorations on premolars, or even better as a second clamp when you're doing indirect restoration cementation. So, you know, veneer lays particularly on posterior teeth, especially premolars, and really good for if you're doing veneer cases as well. So it's really handy for that. But works like that. We have our anchor clamp on the most distal tooth. And if we didn't have that accessory clamp, I mean, you could try using a floss tie, but sometimes floss tie, you get all the resin and everything caught in there, and sometimes it can be a little bit messy. So I like the clamp for that, and it just gives you that retraction that you need. And then you got your 212 butterfly clamps. So they're generally, I mean, I use them for kind of anterior endo, okay, but they can be modified. And just by, again, taking a high-speed handpiece, you can cut them in half and adjust the kind of beaks of those, and you can use them like a B4, just like the previous slides. But generally, like I said, I use them for anterior endo. They work really nicely. But depending on the quality of the tooth, sometimes what I always keep on hand is like Adams pliers. So sometimes you can just bend the beaks a little bit just to get a little bit more grip on the tooth. Obviously, don't bend them too much, because what you don't want them to do is start stripping the gums away from the teeth. So we'd be careful. But the most important thing, and I need to do a lot more, okay, so I don't always practice what I preach, but need to floss the clamps, okay, because the last thing you want is these things breaking, because they can, and, you know, going down the back of your patient's mouth. That would not be good. Doesn't matter how you floss them, just secure it from one end to the other, okay? You just need to secure both ends, because where it's going to snap is where the bow is. So as long as both bits are secure on either end, it doesn't matter, okay? So there's no fancy technique for tying the floss tie. Best thing to do, pass it over to your nurse, get her involved. That's one big thing that when we're teaching courses that dentists don't do, and you actually see them doing it on the courses, like they just want to do everything themselves, but actually trying to just do and place a rubber dam on your own is difficult. You actually need 2 hands, especially posteriorly. I'll often place my clamp, get my rubber dam around and onto that clamp, and then the subsequent teeth, I'm having my nurse there stretching the rubber dam and holding it so that I can then floss it between contacts. Trying to do that on your own is just really difficult. It takes too much time. Rubber dams start to tear. You just get frustrated. Okay, your nurse doesn't want to be sat there doing nothing. That really would like something to do. Give them something to do, okay? I know some of you might say, well, your nurse is not engaged, but, you know, if you can engage them and teach them, you might get something from them, get them involved in that. And nurses can actually be trained to place rubber dam. I've been to practices where their workflow is actually their nurses place the rubber dam. They'll actually be out of the surgery, maybe seeing someone in another room for a checkup, and they'll come back in and nurse has actually placed the rubber dam for them. I mean, it's brilliant, and it works. So when you're holding the clamp as well, I mean, again, it seems obvious little things, but I always find it's always the little things that cause problems with people. And, you know, if you just kind of get those little things right, you know, all adds up and just really makes the overall procedure a lot easier. But when you're trying to engage clamps, all clamps are slightly different. If you look at these soft clamps, they have these little walls, these little projections. That's where the clamp forceps need to engage. You don't need to actually force them into the holes that you see, but actually just engage those walls. Because it's when you force them into the holes that's when you struggle to get the forceps out, and you know that's when the clamp can sometimes not be seated in the correct position because you've kind of moved it from where it's needed to be whilst you've been trying to get the forceps out. And then you've got the metal clamps, and these you do just need to engage and kind of put the tips of the forceps through those holes, and that will hold everything securely. And then the last thing is just like little things, just how you hold it. I often hold it in this underhand way. Why do I do that? Because I find often, for me, the position I'm approaching the patient is always kind of 12 o'clock, okay? And it's just easier for me to hold the forceps in that manner because there's less strain on my wrist as well. And I can actually see what I'm doing a lot better and just a lot more control. So actually try it that way and you'll find it's quite useful. So guys, that's what I've kind of had to talk about clamps. I hope that's been useful, but I guess I wanted to give you a little bit of a bonus in terms of floss ties, because floss ties is something that a lot of people are always kind of curious, how do you tie a floss tie? And they don't really know how to do it. So what I'm going to try and do today, I mean, it'll be a bit of an experiment, is try and show everyone how to do a floss tie, okay? So I'm going to show you on a shoelace because it's just a little bit easier to see. But what I'd like everyone to do is, if I'll give you all 2 minutes, just run somewhere, go and get some floss. I'm hoping you're all dentists and you've all got floss at home. If not, I don't know what to say. But go and get some floss. Okay, so I'll give you 2 minutes. How are we doing, guys, on time?
Fantastic, you did well. I mean, whilst everyone's running to get some floss, running to your bathrooms, not to the local shops to get floss, but make sure you have got it in the house. We've got a few questions I want to ask whilst we're on it. Where's it gone? Army, at the start of the lecture, you talked about an endo paper. So Abbas is asking, what was that endo paper?
That was the European Society of Endo. Can't even say endo. Don't look. Bloody hell, mouth's gone dry. But yeah, European Society of Endo. Basically, it's their guidelines. If anyone wants it, I can always forward it on to you. But it's available, I think, online anyway for free. So it was their guidelines, and I think that's only come out in the last year or so.
Fantastic. So Abbas, I mean, if you want to message Harmeet on social media, Instagram, he can send you the link. Go onto the Endo Society's website. It definitely is available. But as I said, you send Harmeet a message and he will have a look as well. Yeah. Brilliant. So I'm hoping everyone has got some floss. John, you got some floss? I think Kish has gone running to the shops looking for it. Definitely.
All right, Jim, tell me, can you see that this shoe? Because I can't see my screen. What I'm seeing on here, but can you see? Hang on, let me just see if I can do this.
I'll just come out of the presentation for now. 2 minutes, yeah.
All right, here we go.
Let me. Yeah. Is that better?
There we go. That is better. Yeah, I can see what I'm doing. So I'm hoping, can everyone see? I'm going to step back a little bit, but can everybody see? I use the shoelace for this reason, because it's easier to see than floss, okay? So I've just got one long shoelace, okay? But can everyone see that? Just quickly type in the chat box if you can. There we go. I think everyone's good, yeah. All right, lovely. So what I want you to do, I'll do it a few times, but just watch me initially, okay? And then hopefully you can follow, okay? So just watch me. I'll do it a couple of times, and then you guys try it as well. But I always find actually doing it initially on the shoelace, just to get the technique right, is good, and then try it on floss. But what we'll start off with is one long piece of floss, okay? So imagine that's one long piece of floss, and I just bring the two ends together, okay? And then pinch them there. And what that automatically does is it's just created this little loop here, okay? So what I then do, just the top of the loop, I just pinch it with my fingers, and I've just created this little loop just at the top. So the next thing you want to do is those two loose ends, is just thread them through. And as you pull them through, you've just created a little loop there, okay? So that's step one. So once you've got that little loop, get your thumb, index finger, and just put it through there, okay? So all I've done is I've just got that loop and put it over the fingers there. And then the key is just keeping this bit taut, okay? So I'm going to show you slowly. What I do is I just get that long bit and I wrap it around my index finger. Yeah, so it just kind of goes round. So when I say around, it goes towards the side that the fingernail is, which is on pointing toward the outside. And that's what you've got. And then all I do then is just a motion of, it's like pulling the trigger on a gun, okay? It's pulling that long bit of floss just through this area here. That's it. So if I do that, you just go like this, okay? Now at that point, all I have to do is just my thumb, is just take my thumb out. You see how with my index finger, I've still kept that hold. Now right now, looks like a mess, but with a little bit of jiggery pokery, okay? All you do is just get that long bit and just tighten it together. And then what you'll find is it forms this knot. Now, the best thing about this knot is it's self-ligating. So what that means is when I put on the tooth, I don't need to have two hands involved, all right? Just one hand. I'm seeing Sonam there. Don't worry, I'll go over it again if I've lost you. But you just literally, one hand, you're just moving it back and forth, and it tightens itself, okay? Now, first thing for you guys to do is obviously master it yourselves. After that, teach your nurse, then forget about it, okay? Teach all the nurses in your practice, then they do it for you, okay? And they can just keep handing them to you, all right? So you don't ever have to worry about it. But I always find the best way to learn is obviously through teaching, okay? So that'll kind of just reinforce what you've learned. But let's go over it again, okay? And see if you can keep up. If you can't get it, don't worry, okay? I mean, I'll see if I can try and make some kind of video, send it out, and the boys can post it up on social media, all right? But again, one long bit, just bring them together, okay? So you just bring the two ends, the two loose ends together, that's it. And then you get it like that, okay? And now pinch it at the top, forms a little loop. All you have to do now is get those two loose ends and just feed it through the loop. And it just forms this, it forms like a little noose. Now once you've got that little noose, index finger and thumb, pop it over the top. Okay, that's it. So your fingers are kind of like pointing towards the ceiling. Now, key bit is, don't let go of this, keep that, like I said, taut, okay? A lot of people just let go of this, and then that's why you then struggle when you're trying to get the knot together. Now, all I'm doing here is, okay, so pay attention is you've got your index finger. I'll do it a few times. I'm just rotating it around the outside to in, okay? So again, different angle, outside to in, okay? And once you've got it there, you can see this area here. All you're gonna do is just flick your finger through this space. So you flick your finger through. So like I said, pulling trigger on the gun, and then just take your thumb out. Keep this index finger held against your palm and just wiggle it a little bit. And then what you'll find is the noose, the knot starts to form, okay? And that's it. But I wanted to show people that because, like I said, that's probably the best knot I found because, like I said, you then don't need to you don't need two hands, and that's useful anteriorly because sometimes you're trying to put that floss tie on, and you'll find often on the palatal it starts riding up. So what you need to do is just hold it on the palatal aspect with a flat plastic, and then you can kind of, that guides the floss tie around the neck of the tooth, and then you're free to tighten it with the other hand. Okay. But last thing, guys, I'm just going to quickly share my screen just to finish up, and then we can do a bit of a Q&A.
How to do it? Put it in the chat box if you got it. If you're totally what's going on, just don't reply. We don't want to hear it.
All right, so I'm going to quickly share the screen and let's just finish up on this. There we go. So I guess tips for implementation. Allocating extra time. Okay, you can't expect to do things in the same amount of time. Initially, it is going to take a little bit of time, especially if you're doing quadrants. It might take you 10 minutes. Okay, but allocate that time. But you've got to use the opportunities that are presented to you. And right, one opportunity is endo. Everyone's doing endo, but often people just isolate one tooth. But actually, you've got the opportunity there. Why not just, while you're working on that one tooth, why not isolate the whole quadrant? You don't necessarily, well, it actually helps because you get better access, but it's just practice for you. So that when you come into your restorative work, you're a bit more confident. And then using the, like I said, try and see opportunity in everything. I mean, hasn't been a great few months, okay? But like I said, use it as an opportunity. There's going to be lots of what we call fallow time. It's going to be a little bit slower paced initially. You're going to have a bit more time, and people are going to give you that time. So why don't you use this time now to kind of get better at rubber dam while you've got that time? So when we do get a bit, back to normality, you're a bit more, I guess, efficient, and it's a lot smoother for you. So maybe you don't need to add those 10 minutes onto the end of your appointments. And then invest in the right kit. The beauty about rubber dam is you don't need a lot, and it doesn't cost a lot. Ask your principal to buy it, but as an associate, I said just buy it yourself. Right? You can always keep it with you. Okay. So invest in some good quality rubber dam sheets. I use the ones from Unident and the heavy gauge ones. And then just like I said, the 7 clamps that I showed you today, using them, and like I said, that's all I've used and haven't needed to use any more clamps like that. But more importantly, document not just the cases you're doing, but document isolation. Have a look where you could have done better and use that to learn. And just reinforce that by teaching your team. Like I said, it reinforces your knowledge, but also if you can get team members to do things for you, it's even better. And last one, again, cheeky little plug, learn from me, okay? There's lots more that I would love to teach you about, various other aspects around rubber dam placement on posterior teeth, anterior teeth, and more complex cases, dealing with broken down teeth, deep cavities. But there's only so much I can do. But, keep an eye on my social media. Hopefully, when we get back to some kind of normality, the hands-on courses will be up and running again. I run them around the country, Scotland, Midlands, London, and I do quite a few ones for the boys at Smile Academy. So, yeah, just give us a shout, and, love to have you there, and so that we can teach you a few more bits and pieces. But over to you, Jim.
Thank you so much, Harmeet. Fantastic lecture, and the way you went through it, the simplicity of it as well, and the most important bits, fantastic. Totally relevant to general practice, especially in the current times we are all in, but we've got a lot more time to practice as well and selected. So thank you so much. Thoroughly enjoyed it. Every time I hear you, fantastic lecture as well. We've got a few questions here, and I'm going to start off with the first one. This is from Sarah. Sarah, hope you are well. She's asking, recently on a course, I was told GIC takes up to 6 months to fully set. Is this
that? I'd be interested to know what was told and what was the evidence behind it, because I'm always interested. But luckily for me, it was 6 months because they were long-term temps. So if that is true, then great. But I just find that the affinity GIC has for dentine is really good. And I guess in this case, do I always leave GIC at a base? Not always. But in a case like this where there's that risk of exposure, isn't there? Okay. I'd prefer to leave a little bit of lining in there first as a safety net, as a kind of safety net. But it's never at the periphery, if you notice. Or at the periphery of the margins, there was kind of 1 to 2 millimeters of space, and it's all in enamel. So I know at least at my margins, it's going to be sealed well. So I'm happy in those instances just to leave it that. But in terms of the 6 months rule, I couldn't comment on that. But if Sarah, you've got a paper or some kind of reference, I'm always happy to learn. So yeah, let me know.
Kish, anything you want to add to that?
No, I agree with you. So whenever I've placed a GIC and it's, I've kind of used it as a long-term temporary, or then if I ever go back, then if I have to cut back, as you said, Harmeet, I kind of cut back about 2 millimeters, 2 to 3 millimeters, and then layer it over with composite. And that's mainly for very, very deep cavities, ones where I'm a bit concerned about maybe exposure of the pulp. And you don't want to then remove all of the restorative material that you put in 6 months ago. And you just want to kind of put a layer that's a bit stronger on top, ideally something that's kind of going to mimic the enamel, which is then composite.
Perfect.
Yeah, lovely.
Okay, good. We've had Drew Shah on here tonight as well. So those of you guys who know Drew, he sends his regards to you, Harmeet. Drew is the CEO of Dental Tubules. And again, those of you who are members, you will get discounted rates for our courses, and those of you who are delegates of ours get free access to Tubules. So good to have you here, Drew. Let's see what else we got. Ria is asking, in terms of the clamps, what are the 2 anterior clamps you used?
The 2 anterior clamps, they were the B4, and that's available from Colting. They're called Brinker clamps, and then there was that 212 clamp. So they're given different names in different catalogues. So it's just go more by the look of what you see. But generally, the 212 clamp is just single tooth endo. The B4 clamps is like an accessory clamp. So if you'll use your anchor clamps further distal. That keeps everything in place. But then those anterior clamps, the B4s, are useful just to retract the rubber dam so you can see your margins. Particularly good for, like I said, indirect restorations. It's brilliant. Because if you just tried to use those B4 clamps on their own, they wouldn't hold the rubber dam in place. So you need to have your anchor clamps, and then they come in afterwards.
Perfect. Good question there. Another question is from Taha. Taha's asking, when you're doing any anterior work, clamping the premolars, do you always give buccal and palatal LA? So where are you giving your LA for your clamps, which is a good question.
Yeah, I mean, I like to, purely because of the reason, if anything moves during treatment, or I put it this way, when you're starting a treatment on a patient, you don't want them to be experiencing discomfort from the start, do you? Nothing worse than them thinking, oh God, it's already started hurting and it hasn't even touched my teeth yet. Okay, so I think you've given that buccal infiltration, then there's actually techniques that you can use that palatal infiltrations don't actually have to hurt. You can use topical, you can go through the papilla, can't you? Okay, and then gently inject towards the palatal and then top that up once that's taken hold. So actually, or you can use devices like the ones. So by actually just having a bit more finesse with your anesthesia technique, it's more comfortable for the patient while you're giving anesthesia. But when you put that clamp on the tooth, they're not going to feel it. If you need to move that clamp, they're not going to feel it. Because it's one thing with the Kerr clamps, the soft clamps, when you've got a metal clamp, they're sharp. The last thing you want to do is kind of them to dig in. But if you're adamant that you don't want to do that, you just need to put the clamp on quite gently. So when you put it on, kind of rest it against that palatal and then close it from the buccal, but very slowly. A lot of people just let it go and then it's like pings onto the tooth, but actually you just need to close it into contact, and then hopefully you don't get things pinching the gum.
Fantastic.
Patrick.
Buddy?
So we've got a question here from Connor. Connor, how's it going, mate? Hope all is good. Any tips to prevent the sheet from scrunching up once it's in situ? I think Connor's asking more from a aesthetic perspective, making it look pretty for your photographs.
Yeah. What you can find is sometimes if you just, say, I know you're doing like a 6 and a 7, and if you just isolated a few teeth, sometimes the rubber dam can ride up a little bit and it can kind of start to fold up on itself on the buccal. So there's two ways around it. Sometimes just stretching the dam out and then engaging it onto the frame a little bit more is one way. But sometimes that doesn't always work. I actually find that isolating more teeth is more effective because you're actually stretching the rubber dam out along the arch so it doesn't start to ride up and you don't get that scrunching effect. So actually isolating more teeth. And it's just better. Just gives you better access. And, you know, again, like I said, it's just practice as well.
Perfect.
Harmeet, Amrita is asking a question regarding nurses. What's the best way to get nurses involved in rubber dam or handed dentistry? And what do you recommend in terms of training them up as well?
The way I used to do it was kind of, if you can, and you've got the kind of team member, just ask them, can I just place rubber dam on you and the rest of the team watch? That's a good way. Okay, and just place the rubber dam on that, on that staff member, and then teach everyone that way. If it's the case you've got a patient in the chair, then just teach them there. Just tell them what you're doing. Tell them why you're doing it, because a lot of people don't know. Okay, and then tell them what you'd like them to do. Okay, so when my nurse first started working with me, Jess, I kind of said to her, "Okay, Jess, I'm going to hold it here, and this is. I want you to put your finger here. I want you to put your finger here." And it's literally a case of getting their finger and putting it where you want. Okay, they can't read minds. We've got to kind of talk to them. We've got to kind of guide them, and do that a few times. And over time, you don't have to tell them anymore. But I think sometimes we're kind of, as dentists, we're kind of like, oh, they might not like us telling them something. Maybe you feel like embarrassed to say that in front of the patient. But, you know, I think the patients appreciate it, and the patients are quite interested as well, hearing you kind of talk about what you're doing. And I think they find it quite nice that you're taking the time to impart your knowledge to someone else. So that's the way I'd do that.
Brilliant. John, any tips you got in terms of getting the nurse involved for rubber dam?
I find that, well, any nurse that I've worked with in the past, especially the one I work with now, they respond really well when you involve them in what you're doing. I think it's a really important thing. And the majority of nurses are keen to learn more. They want to get involved. And I can't remember who it was who I spoke to. It might have been you actually, Harmeet. When you're doing like a lovely smile makeover and whatever, and then you sit the patient up, patient walks away, and then the nurse turns around and says to you, "Oh, what a great smile makeover we did." They feel more involved rather than just, you know, it's not all the dentists. If you involve the nurse more, they respond really, really well, I've found.
Yeah, definitely. I love it when they get involved as well, because the patients do look to the nurse, don't they? They don't look at us. They're looking at the nurse like, "What do you reckon?"
Yeah.
Never look at us. We've done that. They're like, "What do you think?" And they'll go into the waiting room and they'll have the conversation with that nurse and the receptionists. And you're like, "God, I wish they'd say something to me," but they're saying it to everyone else. So it's good. And over time, even the nurses get like, and I love it. Some of the nurses I've worked with, they say, "Well, you need to, can you put a bit of composite there? Or you need to polish it a little bit there." And I love that. And I even say to them, like, once I kind of step away, because your eyes are tired, like, "Jess, what do you think?" Like, it's a team effort, isn't it? And I genuinely, I picked your nurse will love you for that, but your patients love that as well.
Fantastic. Definitely.
I totally agree with that. Yeah, totally agree with that. We've got a question from Vidi. Is it true you shouldn't use rubber dam for resin bonded bridges? She's been told mixed things at university. And I think because obviously where you place the resin bonded bridge, sometimes if the rubber dam is in the way, the bridge doesn't seat all the way. What's your thoughts on that?
Yeah, it's comfy. You can definitely use rubber dam and get good isolation for resin bonded bridges. But what you have to do, imagine you've got kind of two teeth and a gap. What you've got to make sure is that when you punch those two holes, the distance is quite large. You kind of overdo it, so that when you've got that rubber dam there, it's just completely slack. Whereas if you kind of leave the holes too close together, it's going to act like a bit of a sponge, like a bit of a trampoline. So when you put that pontic, it's going to put pressure on it. So then you just have to be more careful holding it in place. But definitely punch the holes further apart so there's some slack. But if you're still not confident, just do a split dam. Okay. Again, it's not absolute gold standard isolation, but it's still great isolation. You can put some retraction cord in the sulcus just to control any crevicular fluid, but you're still stopping all that condensation from the breath. But one thing you just got to remember is it's like you're just creating a little bit of a nice working environment for yourself. You know, you can turn around and you can reach for the bond or do something or go and grab your camera without the worry that the patient's going to lick their teeth, sorry. So it's that, for that reason, you know, that I use it more than anything. But you can definitely use it with resin bonded bridges. I just find sometimes you hear these stories, but sometimes it might be that people have just had a bad experience when they've used it, so then therefore they say, all right, you can't do it, but actually you can.
It's a little bit scary, isn't it, sometimes, because you're worried that it's almost like you've got one shot at cementing this bridge in. If you do it wrong, you're screwed. So I think it can be quite off-putting, but like you say, holes apart so that it's not so taut, doesn't lift up. But also what I found and been told in the past, if you get on your metal framework, you can get a little lug that just sits over the incisor ledge, and that way you know that your bridge is sat down properly and you feel a bit more confident when curing.
That's it. And then if it's not got a metal, if it's one a ceramic type, like a Duralay jig or something like that, you can use as well. So yeah, 100% jigs are brilliant.
And your shoelace floss ties as well.
They're thick, man. They give you good retraction.
Just to clarify, Harmeet did mean the patient licking their own teeth, not licking his teeth.
No, I wouldn't recommend that.
Kieran Shankler said, hi, Kish and John. Thank you for putting a good word. Totally blanked me, so I'm going to ignore his question. Someone's asking, any modifications for epileptic patients?
Oh, it's a difficult, because you can't. It depends what you're modifying it for, because what you shouldn't need to modify it for an app, because you don't know when they're going to have that epileptic episode. So I think it comes down to your question when it comes to them, the medical side of things. Finding out when they've had these seizures, how often do they occur? Is it a common thing? And then people have different. Some people go into full on, I guess, seizure. Some people it's more of an aura, isn't it, where they're just still and unresponsive. So it's clarifying what actually happens. You don't, but if it's a case that they haven't had any episodes for a long time, they don't have them frequently, then there's no reason you can't put that rubber dam on in a normal way. You might just be a bit more. Again, you just have to be a bit more attentive. Just make sure you're checking in on the patient and making sure that everything looks okay. That's all you can do. There's no specific modification for the rubber dam itself that you can do.
Just on that,
while we're on the
patients as well, what do you recommend? So question here. So Samir Setti's asking, for patients who are asthmatic, is rubber dam an ideal isolation for them?
Again, depends on level of asthma, isn't it, and how well controlled it is. Because I think if the asthma was to the level that it's that bad, they probably wouldn't be at the dentist in the first place. You'd want to get a handle on that first, really, wouldn't you? If there's that effect. But I've had asthmatic patients. We use it on regularly, and it's fine. Again, it comes down to more than anything, it's how you explain something. Because sometimes the anxiety is not necessarily from the rubber dam; it's from you just haven't explained it. It's like, you imagine someone's come in there and this is all, maybe you're a new face to them, and suddenly you put in this rubber dam. It's equivalent of just getting a stranger and sticking a carrier bag over their head. All right, not recommended. But what I'd say is, before you see them, so say it's a checkup and you're planning treatment, talk to them about what you're going to do, especially if they haven't had treatment with you. So this is how I approach my work. Show them pictures of your work. I have a little picture on a PowerPoint that's zoomed out with a patient of a rubber dam, and the patient's obviously looking happy about it, and show that to the patient. So this is what it looks like, and this is why I use it. And they're like, okay, cool. When they come in on the day, pop the rubber dam on, say, listen, I'm just going to give you a little moment to get used to it. Tell them how they can breathe. So you can still breathe fine. Okay, tell them you can still swallow. I normally tell them, if you need to swallow, you can close slightly. You might find you can't close fully because they're clamped slightly in the way. Or just push your tongue against the rubber dam and swallow that way. Just give them a bit of control. Give them a few minutes before you start. Let them get used to it. And by that time, they've chilled out. And then you do the treatment and you'll find that they say, wow, that was really good. And a lot of them, honestly, they just fall asleep. You hear that little snoring throughout the treatment. And then suddenly they little jolt and then they're back into their nap again. So it's brilliant.
Lovely.
Excellent. Yeah, I think communicating with them is the most important thing, especially if they're slightly anxious or worried about it. I think you've got to talk your patient through that whole journey, and that'll just put them at ease, especially when using rubber dam.
I mean, yeah.
So we've got a question from Anjali. Anjali Buva, how's it going? Hope all is good. With COVID, we're going to have to cover the nose with the dam. Any tips on how to do this effectively and comfortably for the patient?
Yeah, there is that, and that's something I guess we've got to think about. I mean, if you wanted to kind of keep that distance, I mean, it's a difficult one because you can't get everything perfect, can you?
No.
You know, they're still, even with the dam on, they're still going to breathe, and their breath's still going to escape into our atmosphere. Okay, we can't do everything perfectly. I mean, unless we find some filtration devices for their noses, I don't know. But I think covering their nose you could try, but it's patient to patient dependent, isn't it? Just be prepared to have some scissors on hand, and you might need to cut it away. Or if you're adamant you want to cover their nose, maybe some kind of cotton rolls just to prop things up. But again, it's still not secure, and it's still going to cover their nose. So I don't think there's any way you can cover their nose perfectly. I think the main thing for us is not it's the aerosol. It's how kind of everything's going to kind of be spraying up once it's mixed with their saliva. I think that's a bigger concern as well, isn't it? So yeah, I'd like to give you an idea, but even I don't know really.
Good question.
It is difficult. It is difficult.
John, with a question.
We've got a question from Matthew. Hi, Matthew. You all right, mate? Thanks, gents. Very useful webinar. Any tips on rubber dam inversion?
So inversion, I mean, sometimes I often find just using the floss. People often think you need to use flat plastics and things. Often the rubber dam doesn't invert. One, it can be the quality of the rubber dam. So using like a heavy gauge rubber dam is really good because they get good inversion with that. But actually making sure when you floss the rubber dam through your contacts, you've made sure it's actually through your contacts. And then sometimes just actually, much like you'd floss your own teeth, you're hugging your tooth. If you just do that, the rubber dam will actually just follow the floss and it'll just tuck in itself. And then what you might then need to do is just run a little probe of flat plastic, a thin flat plastic around the edges, and you'll find just with a few passes, it'll actually just invert itself. But I normally find 99% of the time, just by flossing down, the rubber dam tucks in nicely.
Perfect. Harmeet, Anastasia's asking, what is your opinion on using Optragate instead of rubber dam?
It just depends what you're doing, doesn't it? I mean, Optragate's, it's good, but again, it's all dependent. I mean, are we talking, we're doing like, a big restorative case, you're doing, lots of edge bonding? I don't know. I mean, Optragate's still good because it gives you really good retraction, but you're still going to have the moisture from the patient's breath, and you're still going to have the ability for the patient. Sometimes for me, it's the ability for the patient to suddenly close and then touch that area that you're working on. So sometimes I'd probably say if I'm not going to isolate each tooth individually, I might then just do a split dam. It's still good, and you're still kind of almost getting the effect of an Optragate, but you're kind of taking the patient a bit more out of the equation. But like I said, it's rubber dam's what I use, it's what I do, it's what I'm comfortable with, and but just because I do it, you do what suits you, what's best for your patient as well. And if you feel it's going to be in their best interest to use the Optragate over rubber dam, go for it. No one's going to berate you. Okay, just make sure maybe you're just a little bit more careful. Maybe you've got a prop in there, your nurse is in there readily with the suction, making sure everything just doesn't get disturbed, and maybe you have to work a little bit more quickly.
Perfect. Good question there.
Got one more question from Anastasia. In cases where it's difficult to clamp a 7 due to an impacted 8, how can you overcome this in order to isolate?
Okay, so good. I mean, hard to say without seeing something. I mean, you could just take out the 8 first. But what I'd probably say is it's difficult if it depends what you're doing on the 7. I'm presuming that are you restoring the distal of the 7? Then it just becomes very difficult. Say I'm assuming she wants to restore the distal of the 7.
Yeah.
Sometimes you can't always do things in one go. I think sometimes as dentists we think that once we say we're going to restorative that we have to do it there and then. there's no harm in a staged approach. If it was a case that you need to do a DL on that 7 and you want to use rubber dam, you can still use rubber dam in the ways that we've said. It will be a bit more difficult because the tooth you're working on is your anchor tooth. Your bow will probably be in the way, and we know when working on 7s we're limited for space anyway. But sometimes just doing the best you can. It might be excavating as much decay as possible and putting a GI. May not be the world's best GI that you've ever seen, okay? But then maybe just rushing along the process of having that 8 extracted, and then you might then need to go back and investigate that 7 and, you know, restore that 7 if possible. So that's what I'd say if you've got that kind of situation. But again, I'm just kind of trying, I guess, guessing what kind of situation you have. It's hard to say, but like I said, if I haven't explained that very well, just send me a message, and even if you've got pictures or actual case, I'm happy to talk it through with you.
Wicked. Cheers, buddy. Good question. Faizan's got a good question here. Any tips on class 2 cavities where the dam gets in the way of the interproximal, or trying to put a matrix band on without damaging the dam? Good question.
It can depend on your matrix system, first of all. You know, what are you using, like a sectional matrix system, or you're just your traditional types, Toffelmeyers and whatnot. So that's one thing, because your traditional matrix systems can tend to, I guess, dig in a little bit more and tear. You then got to make sure that you've actually inverted the dam properly, first of all, because like I said, a lot of people quickly pass it through, but it's not inverted. So you might find the dam's actually stopping your matrix going down. But also it's the cavity depth. You know, we can't restore all cavities. And then you've got to think, all right, if this cavity is that deep that I'm struggling to get a matrix in there, likelihood is I'm going to struggle to get a matrix in there, and the contact point's probably going to be poor. So then you've got to decide, all right, do I need to crown lengthen this tooth? If you don't need to crown lengthen it, maybe you need to stage it. So you might need to kind of, almost like you do with indirect restorations, is elevate your margin, then using a split dam technique, and then replacing the rubber dam, and then getting the sectional in there once the margin's a little higher. So you just have to, that's why I always say, like, plan your cases, and even like a simple composite can sometimes become a little bit more complex. But if you kind of just analyze this from the beginning, looking at x-rays and using your pictures, have that conversation with patients. And in cases where I've got really broken down deep cavities, I don't even say you're coming in for a filling. I'm saying it's a kind of investigation of a tooth appointment, and then we decide what we're going to do going forward.
Brilliant. Ish.
Yeah, so we've got a question from Jag. Have you tried the Isolite system?
Yeah, I did try. I tried it in last practice, and it's okay. I mean, it looks better than it is, in my personal opinion. Some people love it. The only time I found it useful was for children. Okay, if you're doing fissure sealants and things like that, because rubber dam can sometimes, depending on the child, can be a little bit frightening for them. It's essentially the kind of all-in-one, is it mouth prop kind of retractor and suction. But I just found like it didn't help with my access, because once it's in, there's only one way for you to kind of approach that tooth. If you want to kind of approach that tooth from different angles, which often we like to do, it becomes quite difficult. And not everyone's got great mouth openings. Like you see their kind of promotional material, and I'm sure the person has got like 80mm mouth opening, but not everyone has that. So try it if you like it. Like I said,
Perfect.
of course, isn't it? It's what suits you, what works in your hands. Like, you know, us four here, we probably do loads of things differently. So it's just what works for you.
Brilliant. John, questions from there?
We've got one saying, it's quite a good point. Do you have any tips on how to punch holes in the best place?
That's a big topic. I mean, if I was just to give you one tip just to start off with, is like get a good rubber dam template. The one I'd recommend is just the pack dam, it's called. You can Google it and then you can find it. I think like places like Style Italiana and things sell it. But just start there. There's lots of other nuances and things, but the main thing, I think, initially just get good at just placing the clamp on the tooth and just isolating a few teeth, and then start focusing in on spacing and things like that, because there's lots of more complex things that you can talk about around that. But pack dam's a good start. And generally just making sure you've got decent space. There's a rough measurement, and you can't sit down and measure with the holes between, you know, spaces between holes, but as a guide, it's about 4 millimeters. But just to make your life easier, use a pack dam just to start with.
Wicked. Good question. Got a question here from Mineral saying, how can a rubber dam be used for uncooperative pediatric patients?
Ooh. Rubber dam for uncooperative. I mean, it's complex, isn't it? It's just like, it's hard enough treating kids as it is. It's hard enough having kids. But it's again, it depends on the age, isn't it? There's always that kid like that surprises you who's really young and they're just so cooperative, and you can just do all the treatment you want under rubber dam if you needed to. Some that will flatly refuse. Some, it's a process of education, isn't it? Telling them what you're going to do. Actually, rather than talking over them to their parents, talk to that child in language that they're going to understand and trying to tell them what they're going to do. But you might find that if they're uncooperative, like you're saying already, likelihood is rubber dam's not going to help you, because you're not going to be able to get rubber dam on an uncooperative child. So maybe you need to get them to warm to you before you do anything.
Totally agree on that as well. I mean, pediatric patients are difficult. Use other techniques before we look at dam usage as well. I think that is all the questions we've been through. Kish, can you see any more at all? You picked up any more?
No, I think that's everything, man. That's all of the questions done.
Zamin is asking, can we finish on one more floss tie?
All right. One more floss tie. All right, here we go. Here we go.
Party trick, man.
It's nice for me because I haven't worked for months, so this is the most fun I've made. All right, one long floss. Okay, so we grab it by the loose ends, and then you got it like that. Okay, so it just forms there. So just grab it from that end, pinch it together at the top, and you got that little loop. Okay, so then you get your two loose ends and just put it through that little loop. So just like that, and all that does is it just makes a little noose. Okay, so just close that little noose a little bit so it's a little bit smaller, and then what you do is get over your index finger and thumb just like that. Now the important bit is just keep this bit taut. Okay, don't let go of this, otherwise you'll struggle. And then all you have to do, I'll try and show it from a couple of different angles, is imagine my hands like that. I'm just wrapping it around the back of my hand, so kind of where the fingernail is, like that. So just around that index finger. Okay, so now this long bit just sits there between your index finger and thumb, and now you've got to think you've got this area here. All you're trying to do is pull this long bit through here, essentially. Well, the bit that's wrapped around your finger. So think that you're pulling the trigger on a gun, and you just go like this, pull it through. At that point, I keep my index finger tight against my palm and just take your thumb out. And then what you'll find is just, if you just keep jiggling this long bits, this knot will just form here. Okay, and like that. And then you just pull with one hand and it tightens on its own. So if you want, try it on some shoelaces first. It'll probably be easier, and then go over to floss after that. Okay, you'll probably find that it's easier to do on the shoelaces first, and then do it on a floss. So I hope you don't have. Well, I hope you have shoelaces, not loafers. You're good to go.
Absolutely fantastic. I think that is all the questions. Nothing more. Thank you so much, Harmeet. Genuinely an amazing talk. Even I picked up on practical tips I can apply next week when I'm planning to go back to work as well. And as always, enjoyable, fantastic lecturer. John.
Thank you, Harmeet. Mate, we're good friends now after I did your course myself. I mean,
We won't talk about that.
Yeah, that was after that.
The photos look great from that.
Let's just stop for a second. But yeah, really, really good course. That's why we've got you involved with us, because, I mean, talking from experience myself is amazing. And you're now a fantastic friend that I've made from doing that course. So I'd just like to thank you again for coming on and helping us out and helping everyone else out at home. So thank you very much.
Thanks for having me, guys.
Kish.
Yeah, just wanted to say thanks, Harmeet. It was a great lecture, great webinar. And I think one thing that I just wanted to reiterate to everyone is something that you said, which you hit the nail on the head, was everyone now has time to be able to practice rubber dam and become efficient at it. Because I think one of the things that everyone used to say, they don't have time and practice to put rubber dam on or utilize it in the right way. So thank you very much for tonight. It was very, very insightful. And again, you could just see your passion for what you do comes through, and it's amazing. So I think you've helped out a lot of people tonight. So thank you very much.
Thank you, Harmeet.
Thank you, guys.
We've had a lot of messages coming through the last hour or so on our socials, courses, where can we find more about Harmeet? Again, the best way is if you follow us on social media. So Smile Dental Academy, you can follow Dr. Jin, Dr. Kish, Dr. John, and Harmeet as well. And again, as soon as we've got courses going on, hands-on courses, we will let you know. As Harmeet says, he runs them across the country, even up to Scotland as well. So he's going to be starting that up again as soon as we've got the go-ahead from our centres. So the hands-on courses are fantastic. That's exactly how we met Harmeet many years ago on his courses. And again, I would highly recommend that as well. But one thing that Harmeet did touch on right at the start of his presentation was the growth mindset. And I would say everyone, that's sort of something which we go on about daily with our delegates, with our teams. And all of us need to go outside our comfort zone to really grow. What we're all going through currently in dentistry, we're going through together, and the storm will pass. And again, we will reach normality, routine dentistry. A lot of other countries in Europe, America as well, they've gone back to fully normality already. So it will go back to normal. Do not stress out. If anyone needs any support, I know a lot of you guys have already sent me messages for the flowcharts, for our SOPs. If you do need anything, reach out to us. I know it's a difficult time with a lot of mixed messages and guidance as well, but we've been working our way through it so we can help you guys out. So we hope you've enjoyed tonight as well. We've had about 450 of you join us tonight live on Monday night. When we first planned it, I thought no one's going to come on, especially first day back at work. They're going to be too tired or too pissed. But I think a lot of you guys did come on today. It's been fantastic having you. We may plan one more for next week. So if you guys have enjoyed it and you've got any topics you want, drop us a message and we will help you out. And that is what we're here for. But it is 9:30, hour and a half. Once again, thank you to Harmeet for a fantastic lecture. Thank you to Kish, John, and ladies and gents, we're signing out for tonight. Have a lovely week. And those of you at work, keep safe, keep smiling as well. Thank you so much.
Thanks a lot, guys.
Yo, we make the wave, we can never get washed. We don't behave, we don't know about cost. I hit the shots, pick a drop and I floss. I hit the shots, pick a drop and I floss. We make the wave, we can never get washed. We don't behave, we don't know about cost. I hit the shots, pick a drop and I floss. I hit the shots, pick a drop and I floss. We make the wave, we can never get wash. Da Vinci top, back it off cause I'm hot. I'll get the top when I shot a boss. Triple S on my feet while I'm cruising. Ice moonwalkers got your girl choosing. You niggas losing sleep and you're losing. Catch man snoozing, burn and get booted. Yeah, and you see me on the streaming sites. 500 streams, got my t-shirt. My BBS dance.